Okay, good afternoon, everyone, and welcome to this webinar, Improving Home Care Through Analytic Approaches. First of all, sorry for the delay. We had some technical problems, and we have solved them just right now. My name is Jessica de Armas. I teach on research at the University Pompeu Fabra, and I'm going to explain the motivation for this webinar. Well, it comes from the development of the EPHoCaS project, which I'm going to detail a bit later in this session. As I will explain, in this project, we are proposing descriptive, predictive, and prescriptive analytics for logistics in integrated home care. And this analytics helps to make a better use of the limited resources, allowing to extend the benefits of these home cares to an increasing aging population. As an initial case study, we have started with Barcelona, which has its own characteristics from the population point of view, as well as orographic and service points of view. Well, today we developed this webinar where we delve into the value of these analytics, try to understand how they are being applied in other countries and the benefits they involve. We have two leading researchers with extensive knowledge in the home, health, and social care fields, Isabel Gomez from Portugal and Patrick here from Austria, who will share their experiences in the application of analytics in the field of home, social, and health care. I will start by explaining the EPHoCaS project in the back group at the University Pompeu Fabra, and then later, Elena Ramalino will appropriately introduce our invited speakers, and we will listen to their thoughts. While the webinar unfolds, you can ask questions through the chat, which we will answer during the last 15 minutes. If due to time issues not possible to answer, we will do it as soon as possible by email. So now I'm going to start explaining the EPHoCaS project in detail to let you understand what we are doing in Barcelona in this research line. Well, so the EPHoCaS project, the whole aim is the social urgency of a growing elderly population, building sustainable home care services. And well, it is a project funded by La Caixa Foundation. And in our research group, business analytics research group, we try to focus on the well-being of the people on the planet, and we apply operational research and analytics in general for social good. We have different topics or fields like sustainability, development, and particularly this project, the EPHoCaS project, belongs to the integrated home health and social care, aging population, logistics of home care. As I mentioned before, the aim of this project is to guarantee the quality of life of elderly people through our use of limited resources, which allow us to extend the benefits of home care to an increasing aging population. And we try to do it integrating both home social care and home health care. The methodology that we follow consists of three different stages. The first one is the collection of data, try to understand the current scenario, and we apply descriptive analytics in this sense. In the second step, we try to understand what is going to happen in the future. So we try to forecast future scenarios, and we use predictive analytics. And finally, in the last step, we try to react properly to these scenarios, and we put special attention to this third step using prescriptive analytics, since we think that this helps decision makers, policymakers, and care managers to make better decisions, leading to a positive impact on the society. As you can see, the implementation plan consists of 4 different parts. In the first part, we focus on the optimization of supply chain of equipment and appliances. Well, there are some equipments and appliances like wheelchairs, adjustable beds, walkers, required to properly develop home health and social care services, and to allow people to live more comfortably. And the aim of this part of the project is to provide a more efficient use of these equipment. And we had to make decisions such as how many units should be acquired to fulfill the demand, where should they be located, how to manage the inventory of these resources, where the location center or hubs should be to better cover the population, this kind of issues. And some of the benefits and impacts of this part of the project are a better accessibility to resources and equipment, faster planning, better efficiency, lower cost and time to deliver and pick up these equipments. Then in the second step, we focus on the caregiver scheduling. We focus on creating a more efficient caregiver schedules, taking into account many things: absenteeism, rotation, seasonality of the demand, loyalty or continuity of care, skills, interdependencies between social and health care for elderly people, etc. And well, we made decisions or helped to make decisions such as the proper assignment of caregivers to users, or the sequence or scheduling of the services to be done for each worker in each day of the planning period. In this sense, some of the benefits and impacts are better care services for users, but also for workers, a faster planning, improvements in the number of services developed in the period, which is quite important since we can extend the benefits of these cares to more people, better prepare in case of last minute changes, and finally, lower cost. Well, in the third part of this project, we are going to focus on the caregiver transportation. We try to provide an optimal transportation system for the delivery of home care to elderly people. And that way, caregivers can forget about parking or any other activity different from their job. And some of the decisions that we had to make in that sense are the size of the fleet, the composition of the fleet, how to coordinate the assignment of services to vehicles, each planning horizon, how to distribute the cost between both entities, or how to react when new users or jobs appear, this kind of issues. Some of the benefits and impacts in that sense are faster planning again, savings in time looking for parking, improvements in the number of services developed in the period, better prepared in case of last minute changes, lower pollution, which is quite important nowadays, and lower cost again. And finally, in our last part of the project, we try to focus on the mobility. Sometimes citizens who need home cares have to leave home for medical treatment or tests. And in this case, there are mobility services, both health and social, to provide these trips. Well, to improve the mobility of elderly people related to social and health care, we propose some approaches to make decisions such as the quantity of vehicles in the whole system, the kind of vehicles that should compose that fleet, the location of the vehicles, which vehicle has to be assigned to a user when he or she informs about the need, or how to create the routes that should be developed. Again, we have some benefits and impacts: faster planning, better quality of service, improvements in the number of services developed in the period, better actions facing new demand, cancellation, traffic jams, and lower cost. So, well, this is the whole implementation plan, and we have progressed in the first two parts of the project. We have 3 tools almost finished for the bundle movement in the City Council for inventory, location, and transportation. And we have a first version of an approach for the second part of the project, where we are working with the City Council again and with the primary care centers. And regarding the last 2 parts, we are starting, but well, we have more than 1 year yet to finish this project, so we are evolving properly. The overall impact and benefit that we can see in this project are better use of resources, better schedules, better planning, and finally, lower cost and better quality of service. So the question is, how have these decisions been made in other countries or in other areas? Today we have 2 researchers which have experience in these topics, and Elena is going to introduce them.
Okay. Thank you so much, Jessica, for the nice presentation. So today we have the pleasure to have 2 of the leading researchers in the area in Europe and I think in the world. So the first one is Parthic Ich. Parthic Ich is an associate professor and deputy head of the Institute of Production and Logistics at the University of Natural Resources and Bioscience in Vienna, Austria. This university has about more than 14,000 students and about 2,000 scientific staff. Patrick is a study program coordinator for the doctoral studies of social and economic science at the same university. And he has authored more than 60 scientific journals, articles, and books on this area. He's the co-founder of the university spin-off company known as Ingentus, which is a decision support system company which develop systems for healthcare and the youth industry. His research interests include healthcare logistics, sustainable transportation, and disaster management. Professor Hirsch is a leading researcher in healthcare logistics, and he led several project applications on these topics. So thank you so much, Patrick, for attending the conference. And I leave the floor to you. I introduce the second speaker just before she talks, okay? It's all yours, Patrick. Thank you for coming.
Thank you very much for the invitation, and thank you very much for the introduction, Elena. So I will start to share my screen. So I hope you can see my screen.
Yes, we do.
Okay, thank you. So I'm going to talk today about the home healthcare routing and scheduling problem. And I want to give you also a little bit the practical point of view of that topic. And also I want to tell you something about promising future research directions in that area. So I was starting to work in that area already in 2008, together with the Austrian Red Cross, which is one of the leading home healthcare organizations in Austria. So they have, in each federal state, they have a lot of nurses and a lot of clients that they care for. And so it was very interesting to start with them working in 2008. And I think up to now, we exchanged a lot of knowledge in that area. Then it was also joint work together with the company Ingentus Decision Support, which is a spin-off company of our university institute. We have founded that company in 2012, and since then we tried to develop decision support tools also for home healthcare services, and one of these tools is already in use at the major home healthcare service provider in Vienna. So just a short introduction. I think you have already mentioned why it is so important to care about home healthcare. On one hand side, it's about the demographic changes. So the portion of the elderly persons is increasing in industrialized countries. Then we have the changing family structures. So more and more people are living alone in industrialized countries. Children do not stay in the same area where their parents live, so they tend to move away. And so we have a higher need for formal care here. Then again, I think it was also a little bit forced through the Corona crisis, because when we looked at the number of infections, we could see that in care homes we had very often clusters, and I think this will also force the trend to grow old at home in future. So many people like to stay in their own home. And of course, if we look at this from the governmental point of view, we can also see it's much cheaper if people stay at home than if they would go into intramural care facilities. So we have different qualification levels in home healthcare. So starting from home helpers, we can see that on the picture here to the left, who help elderly people to to prepare them some food or to assist them in the household. Then we have assistant nurses who are dealing with changing the bandages, who are dealing with washing the clients. And then we have qualified nurses who do more medical work at the clients. So just to give you some numbers, I think Austria is, in terms of population, a little bit bigger than Catalonia, I guess about 1.5 million inhabitants more, but I think both are quite comparable. And so in Austria in 2019, we had 16.7 million hours worked in home health care. About 153,000 clients were visited at home, and we had about 12,600 full-time equivalent employees in home health care. When we look at the growth rate between 2014 and 2019, we can see that the hours worked in home health care have increased by 3.8%, and the number of full-time equivalent employees have increased by 8.2% during that period. So what we discovered in our work was that there is a need for decision support systems to improve the routing and scheduling of home health care nurses, especially in Austria. If we look to more rural areas, we can see that home health care nurses spend up to 30% of their working time traveling from one client to the next one. So when you account for working time of around 8 hours, that means that they spend nearly 3 hours just traveling from one client to the next one. And there is a huge potential there to improve the situation by assigning nurses better to clients and by improving the routing. So if we look to the practice up to now, so the routing and scheduling is still done manually by most of the home healthcare providers. When we look at the transport modes that home healthcare nurses travel with, so the predominant mode here are cars, but in urban areas, it's also very common that they use public transportation. So for example, in the case of Vienna, here the Austrian Red Cross use it. Here 90% of the nurses of the Austrian Red Cross use public transport instead of cars, which also brings us to new problems for doing the scheduling of these nurses. So what are the requirements? We need some commercial software solutions to solve the home healthcare scheduling and routing problems. And if we look to the literature, we can find now a lot of papers on home healthcare, but it's very important here to see what the organizations need in practice and what kind of constraints they need in practice. And therefore, I tried to give you an overview afterwards about all the objectives we have seen in literature and also about the constraints we have found also in theory and in practice. But first of all, just the story, how it all started. So you can see here a picture of a small town which is located in the northwest of Austria. And when we started our first project on home healthcare, we didn't think so much about optimizing the routing and scheduling. So our first aim was to provide the Austrian Red Cross with a plan. What happens if a flood disaster occurs? And here you can see the city where it's not a city, it's a small town where two rivers flow together. One is called Steyr, like the town, and the other one is called Enns. And this town is, let's say every 2 to 3 years, a flooding happens there. And you can see the same picture here with the flooding, and you can see that it's impossible to go over these bridges. And if you look at the satellite picture, If you have here the facilities of the Austrian Red Cross where the home care nurses start, you can see here that this would be the common routing of the home care nurses. And if you have the flooding, as you can see in the picture on the right-hand side, you need to think about which are still streets that you can use, which are still bridges you can use. Are there maybe clients that you can't reach anymore? And do you have plans? Do you have to make plans how you can evacuate these clients maybe, or how you can rearrange your routing? And when we were thinking about that, we discovered that they didn't have any decision support for the routing and scheduling of the nurses. And then we decided first to provide them with a system how to optimize the routing and scheduling of the nurses. And therefore they could save a lot of travel time, and therefore they have more buffer in case that a disaster happens. And of course, then we had also to undertake other research, like what do we do if some clients are not reachable anymore, and how do we find alternative routes for the home care nurses. So that was the history, how it all started. And now I want to give you a list of constraints in home healthcare that we have discovered in the literature, but also in practice. Of course, we have the hard time windows of the jobs at the clients. So depending on if they get some medication, if they get some injections, if they get a change of bandages, this has to be done usually within a certain time frame. But in reality, clients often demand also soft time windows, because some clients like to get up very early in the morning, other clients like to sleep a little bit longer, and therefore they have also preferences for so-called soft time windows, because usually the organizations can't guarantee that they fulfill these preferences, but they try to fulfill them as good as possible. Then, of course, we have the skill requirements, and the skill requirements are not just medical skills of the nurses. It's also, especially in urban areas, we have to be sure that the client and the nurse can communicate with each other. And here, spoken languages, especially in Vienna, is a big topic, that the nurses are also able to speak the language of the client. And then, of course, we also have sometimes the need for specialized social skills, because sometimes also the clients are already a little bit mentally ill, so and you need special skills here of the nurses. Then, of course, we have some assignment constraints between nurses and clients. For example, if the nurse has a pet allergy, she can't go to a client with cats or with dogs. And then, of course, we have preferences for nurses, which we could have as a soft assignment constraints. Then we have a lot of working time regulations for the nurses. So usually we have a contracted working time for the nurses. Here in Austria, we have the case that we have to guarantee a minimum working time due for the nurse and a maximum working time. So the difference between the contracted working time and the maximum working time is then the overtime that is made by the nurse. Then we have the problem that most of the jobs are during the morning hours and during the afternoon. So there's usually not so much to do during noon. And therefore, we sometimes have to assign 2 shifts to nurses during a day. And of course, it is not very comfortable for a nurse to have a break of about 4 or 5 hours during noon. And therefore, we also tried to minimize the number of shifts and tried to reduce that to 1 shift per day. And then, of course, also the nurses demand sometimes some working time windows. And so we have also to deal with that. Another very complicated thing were the mandatory break times of the nurses, because they were dependent on the working time of the nurse, which we did not know in advance. And we have a lot of special rules, because one rule which is quite easy is that after 6 hours of work, they have to take a break of half an hour. But some organizations do it that they can split that break into 2 breaks or into 3 breaks. And so that adds another complexity to that problem. Then, of course, we also have to deal with the precedence constraints of jobs. For example, the client needs to be washed before a medical treatment is done. And so the washing is done by an assistant nurse, and then the qualified nurse does the medical treatment, for example. So we have here a precedence that we have to observe. Another thing which we discovered in our work, and I wrote it down here as an example, is also very common in practice. It's like if you visit heavy smokers, clients that are heavy smokers at home, you can't do that at the start of the route because you smell, and the other clients and afterwards in the route would complain about that. And so you also have to take care about that in the order of the visits. So this is maybe one thing one would not think of in the beginning. Then, of course, we have also the synchronization of nurses. If we need 2 or more nurses at the same time at the client, and then we also have to think about the continuity of care constraints, so that a group of nurses visits the same client, or even the same nurse has to visit that client. And we were working with one organization who told us they don't want to have that continuity of care in their organization because they don't want to have a personal relationship between caregiver and client. And we have worked with other organizations for whom that was very important, that always the same nurses or always the same group of nurses gets to the clients. So this is also one thing in practice which one has to clarify with the organization, with the home healthcare organization. So what were the objective functions we have discovered? So in our case, it was always mandatory that all tasks, all jobs have to be done. So for us, it was clear that we need to fulfill all the jobs, and that we also have a fixed number of nurses that are employed by the home healthcare organization who will do that job. So we didn't minimize the number of nurses, and we had the fixed number of jobs. But what was interesting for the organizations we have dealt with was to minimize the travel distances. We could also translate it to travel times or the cost. To include the waiting time, that if a nurse arrives too early at the client and the hard time window hasn't started up to then, that this waiting time is also counted. Then, of course, we have to deal with overtime, and we have to deal with the slot constraint violations in the objective function. And another thing that is important for some organizations is the fairness, so that the workload per nurse is quite equal. So then, of course, we can also think about an extension of the planning horizon. So here again, we have to think about the continuity of care over a longer period. And if we think over the daily planning horizon, we have to think about additional working time regulation. So we have minimum rest times between the single shifts, minimum rest periods that are mandatory within a certain time span. We could think about visiting patterns of the client. So if we extend the planning horizon from the daily planning we have to deal with other constraints. So what is the planning environment? Most of the papers in home healthcare assume a static information at the start of the planning horizon. When we also want to deal with the uncertainty, we could maybe think about client monitoring. I've heard that for healthcare organizations in Canada or in the United States, where they also have some monitoring tools for the client in order to tell the home care organization if it is necessary to visit that client or not. And we should think about the possible sources of uncertainty in home healthcare, like the travel time length, like the job length, because the job length is very dependent on the health condition of the client. And sometimes the nurse needs to stay a little bit longer in order to help the client. Then, of course, also the number of jobs during a day is a little bit uncertain because sometimes clients are hospitalized during the day or other clients are come home from the hospital and need to be cared for at home. And then, of course, we also have that nurses call in sick or that nurses cannot start that duty, and so also the number of available nurses is sometimes a little bit uncertain. So you can find some dynamic and stochastic solution approaches in literature. When we talked to the organizations we worked with, they were more interested in a robust planning than in dynamic adaptations during the planning horizon. So what could be examples for external factors that lead to an increase in uncertainty, like we have seen in the pictures before, natural disasters, blackouts, or pandemics, and we have also seen it during the Corona crisis, that we had to do some replanning. For example, here in Vienna, the public transportation worked less regularly than during normal times. So the intervals between the subways, the intervals between the buses were much longer than in normal times, and therefore also the routes of the home care nurses took much longer. And so then, of course, you also have the other things during pandemics, like more clients, maybe like nurses that call in sick. Okay, so I will hurry up a little bit. So what do we need? We need emergency plans. Yeah, we need to know about the informal care potential. We need to know about, can we maybe transfer the clients to intramural care facilities? And in the worst case, we have to think about a triage of clients. So when we think about transport types, we have unimodal ones, which are car, walking, or using a bike, for example, or multimodal ones like public transport, where we can use a mix of bus, tram, subway, and train, and also walking. Then we have time-dependent transport modes like public transport, and time-independent ones like using rural routes in rural areas. Then, of course, we can also think about sharing of trips, like bus services for nurses, or sharing of vehicles like car sharing or bike sharing. So since I already run out of time, I just want to go over that quite quickly. So here, this is a case study which is dealing with the planning of home healthcare services in Vienna, where we use a combination of bus, tram, subway, train, and walking. And it is very important because 90% of the home healthcare nurses of the Austrian Red Cross use public transport solely in Vienna. And the thing here is that depending on the time of the day, the shortest route between two clients, they are marked here as rectangles, is changing. For example, if you start at 10 a.m., the shortest route would be that one by walking from the client to the subway station, taking the subway and walking to the client. So the other route would take longer. If you go to the bus, then change to the tram and then walk to the client. But if you start 5 minutes later, the things might change and the other route might be the faster one. So depending on the time of the day, you have different shortest paths. So what we did here was to first generate the walking routes based on OpenStreetMap data. And then we also made the time-dependent public transport matrices on a minute basis for Vienna. Of course, if you take that for realistic instances, it's not possible to solve that with exact methods or with standard exact methods like in Solver software. Therefore, we provided different taboo search solution approaches. And of course, we had to think about many things during the implementation. So we did that for real-world data of the Austrian Red Cross. So the number of jobs were up to 202 jobs, number of clients 127, and the number of nurses up to 46. In total, we had around 1,600 stations in the public transport network, and we had to compute 960 asymmetric travel time matrices because the operating times of the home care services are between 6 o'clock in the morning and 10 o'clock in the evening. So when we tried that with the data of the Austrian Red Cross, we could say here you can just see the different taboo search variants, but we could say that if we use a predefined roster for the daily planning, we could improve the situation by about 40% compared to the initial travel times. If we were also flexible with the working hours of the nurses, we could even improve it more by reducing the current travel times by about 50%. Okay, where can you read these things? These are the papers dealing with the optimization with public transportation. We have also implemented that as a web service for commercial users, which is available via our spin-off company Ingentus, and which is already in use with the big home healthcare service provider in Vienna, where you can read the things about the time-independent vehicle routing problems, the things we have started with. These are published in these papers, and we have also one paper about a weekly planning horizon where we try to solve that with an exact approach. Of course, sustainability in home healthcare is also very important, and it's not just about the environmental concerns, it's also about the social concerns. And if we think about possible transport modes in home healthcare, you can find a lot of different concepts here. For example, you can combine public transport with kick scooters or with bicycles so that you can transport that kick scooter or that bicycle with you in the public transport and can take some parts of your trip with the bicycle or with the kick scooter. You can think about trip sharing systems that you use dedicated bus services for the home care nurses, or you can think about other things that we have tried to list here in that table. So we have also written 2 papers about using a bus service for home healthcare nurses. One is for the static case, and the other one was developed together with colleagues from Barcelona with Untitled in the Enoch Martinez, and this one deals with the dynamic case. But of course, we also have to think about the third column of sustainability, which is the social one. And if we look to the social one, it was very important for us also to talk with the people who are the team leaders or who are the home healthcare workers who are directly affected by these algorithms. And so we took qualitative interviews with home healthcare nurses in different parts of Austria. And it was important for us to see what affects the routing from their point of view. And one thing we have learned already were the external effects affecting the sequence of visits. And we have seen that example of the heavy smoker, which should be at the end of the route. Another thing which was very important for them was the subjective safety when they use a certain mobility concept. Another things that we were not really aware of was that home care nurse is a quite lonesome job during the day because you don't have too much interaction with your colleagues. And so it was also important for them to meet now and then with their colleagues and to talk about potential problems. And another thing was that it was quite important for them to have a space where they could rest a little bit. And so for some of them, it was very important to have a car, because if you have a break, you can go to your car and relax there a little bit. If you're just using public transport, you don't have that possibility. And so there are a lot of criteria you can take into account when you think about mobility concepts and when you think about the optimal routing. So what were the future research directions that we identified in home healthcare? I think robust planning is a big topic to deal with the uncertainty in home healthcare routing and scheduling. It was also very important not just to look at the daily planning horizon, but also to integrate that daily planning horizon into a longer time planning horizon. Then it was important to think about different modes of transport and to enable the home healthcare service providers to do the routing and scheduling with these transport modes. Then, especially since this is quite hard to get staff for home healthcare services, also to care about the things that home healthcare nurses want to have when they are working, also to care about their needs. And this is also quite important also if we think about the sustainability, because we are not optimizing here a system of machines and products. We are optimizing a system where we need to care about patients and where we need to care about the staff who is going to these patients. So it's quite important to care about the social indicators here too. Okay, so where can you read about that? So I've just listed 2 review papers here, and we have also tried to compare a trip and car sharing concept for home healthcare in one paper. And we have also published one book chapter where we were thinking about these sustainability things in home healthcare. Okay, then thank you very much for your attention and sorry for taking a few minutes more. I hope I was not too long.
Thank you so much, Patrick. It's a really amazing, good work that you have done in this topic. We're going to have like one question at the end after Isabel is talking. So let me introduce now the next speaker. So the next speaker is Professor Isabel Gomez. Isabel Gomez is an associate professor at the Department of Mathematics at the Nova School of Science and Technology in Lisbon, Portugal, and also researches as the Operation Research Group of the Center of Mathematics and Application of the same university, University Nova of Lisbon. She holds a PhD in industrial engineer and management from the Technical University of Lisbon. Her research work on the modeling and optimization of logistics systems, mainly in sustainable supply chains, reverse logistics, waste collection systems, and more recently in home health and social care scheduling. Professor Gomez is a leading researcher in social logistics in Europe. She named this area and has done relevant work in this topic. So it's a great pleasure to have you with us, Isabel. Just go ahead.
Hello, good afternoon. Thank you, Elena, for such a kind presentation. And thank you for the invitation in this webinar with such a high level of presentations. So I'm sharing my presentation. Are you seeing my presentation? Is it okay?
Yes, we do.
Yes? Okay. So I've been working also in this topic of home care services, and I was asked a little bit to talk a little bit about what are the challenges faced by the service planner when planning a social home care service. So Patrick has talked already a lot about this topic. I'm going to present the perspective I have from working with Portuguese associations that provide this type of service. So just to have you a little bit of a idea where I work. So I work in the largest campus in Portugal, a university campus. It's near Lisbon, but not really in Lisbon. Is, we say, on the other side of the river, quite close to the ocean, not as close as Pompeu Fabra is from the sea, but it's quite close. So just to give you an idea of the integrated care services is organized in Portugal. So we have a public national network. It's a governmental structure. It's a partnership between the Ministry of Health and the Ministry of Labor and Social Solidarity. And they provide a different type of services. They have nursing homes for different types of stayings in terms of length. And then a fourth type of service, which is called home and community-based services. So these services provide, well, nurses or caregivers go to patients' homes to provide different kind of service, mostly nursing, medical, and rehabilitation. In fact, this is they work with people with functional dependence and work in teams. These teams are workers from the primary care centers. A recent study, a 2018 study, concluded that although we have all this national network, there's still a dominance of the institutionalization over the home care. And there are lots of regional asymmetries in this type of provision of care. So one of the reasons, I think, this is my opinion, for the prevalence of institutionalization is that these home and community-based service, the public ones, exclude patients without an informal caregiver. So patients living alone or cannot have this type of service, nor patients needing 24-hour care. These need to be institutionalized. And also, for me, this is the most important one, that they exclude patients needing only social care. So if there's no health care involved, these patients cannot apply to this service. And in fact, the private sector is very expensive and the majority of the population cannot afford them. So the social care is mostly provided by non-profit organizations that in Portuguese, they are known as the EPHoCaS, which are institutions for particular institutions private institution for social solidarity. And these institutions are in fact associations that appear to fulfill a need of the population. So it's not the companies that see a market opportunity, is in fact organizations that need to just come up to support people in need. Some of them are parishes, Catholic parishes that provide this service. Others are organizations associated with clubs and those kind of structures. So the service provider are quite different from the service provided in terms of healthcare. So these caregivers can visit patients from just few visits a week to several visits per day. They provide both instrumental and in-personal activities of the daily living, and a very large number of services are provided. They also have patients that are bedridden, and so these patients the tasks demand quite often two caregivers to perform them, while others activities for those same patients need only one caregiver. So there's quite a different demand for caregivers for the same patient. It depends on the task we perform. So as Patrick has mentioned, there's no IT tool, or at least of public of widely spread to help this type of service. And from my experience, Excel is the IT tool, but it's only as a database where they where they aggregate the information concerning the patient, the address, the tasks, and only that, nothing more than that. And usually in this type of organization is a social worker that is in charge of planning the service, and mostly it's a woman, and she plans with pen and paper, which is quite a heavy task to do, because these scheduling problems, and these problems are quite complex in terms of reaching a good solution. So I've been working with the Pompeu, which is a non-private organization. It was created in 1990, and it has several services, from children daycare center to a social canteen where they offer free meals for food emergency, which has increased a lot during the pandemic here in Portugal. They also have leisure activities for the elderly, a very interesting initiative, which is Café Memoria, which is memory cafe for patients with Alzheimer, where they try to improve their memories with some activities. And they also have what I've been working more closely, which is the home care service that they provide. And during the pandemic, so these senior services have been all provided at home, even leisure and some activities to keep the seniors active and not only waiting for tomorrow to come again. So it's been quite demanding for them to provide all these services. And the project we have collaborating in is quite easy to define. So what we want is just to have a daily work schedule for each of the caregivers. So what we want to know is which patient to visit and when for each caregiver, which is quite easy to present. So it's just this. But after Patrick's presentation, you know that there's lots of special constraints behind it and special issues that need to be addressed. So is planning different from home care or health care and from social health care? It seems like the same. So it's to schedule work of caregivers to people's home. So here in Portugal, healthcare is mostly skilled professional, nurses and physiotherapists, while social home care is unskilled professionals. So it's all those activities of the daily living that don't need healthcare tasks. In social healthcare, we may have several visits per day. For instance, for bedridden patients, the caregivers need to be at their home first thing in the morning, and also the last thing in the evening to prepare them for the night. So several visits per day. And in healthcare, at most one visit per day, at least in the Portuguese reality. So each caregiver in the healthcare performs more or less the same type of tasks, while in social caregivers provide very different tasks, some demanding one caregiver, others demanding two caregivers. So this is also a difference in terms of planning. I'm only looking through the glasses of planning, okay? And then we have continuity of care, which is to have the same caregiver, or at least the same caregivers to visit the patient. And I have put it in both columns. However, they are quite different. So Patrick, you briefly mentioned that some of the companies you work with, they do not want this continuity of care. And here in Portugal, many of these social organizations, they don't want the continuity of care, as we see in the literature, which is always the same nurse to attend the same patient. And this has to do with the personal relationship that is developed between the patient and the caregiver. We might think it's good to have a personal relationship, and it is, it's good. However, there are lots of problems that come up with this relationship. Either sometimes the elderly are very demanding with these caregivers. They do not allow them to arrive 1 minute earlier or 1 minute later. They not allow them to change the way things have been done by them for a long time. And so you have to always to put the broom in the same place, and you always have to put the bucket in the same place. So there's lots of small issues that come up in this type of long-term relationships that are professionals, but people tend to mix up the relationship. And the other way around also. The caregivers feel too much at home and sometimes do things they should not. So one of the social workers in one of the meetings told us that there was a lady whose daughter baked her a cake every weekend for her to have a cake during the week. And the caregiver was once offered a slice. And since then, every time she visits the lady, she would have a slice of the cake. So at the end of the week, the cake was mostly eaten by the caregiver and not by the lady, the patient. So there's this type of relationships. I don't know if they are really a South culture way of living. I don't know if this is a reality in Spain, but it's quite common here in Portugal. And so the caregivers, the social workers that work with us asked us for special continuity of care. So they don't want random visiting plan, but they want to have some specific rules that I will explain a bit later. And these are the rules. I thought it was a little bit later. So what they ask is that there was, the caregivers were the same for a week, but then each week they should change, but not in a hazardous way. So at least one of the caregivers, they work in teams of 2, at least one of the caregivers should be the same, and the other should change. This for the bedridden patients, which are the more demanding patients in terms of services. And this caregiver should be at least 2 weeks or at most 3 weeks. And this should change. The caregivers should rotate between each other. So they work in teams, all the caregivers should work with each other. and should visit all the patients so that everyone knows everyone, because these are quite often long-term relationships. So it's not really some weeks, it's more than, it's months and years. And this is the planning they ask us. So to add to when to visit and which page to visit per week, we also have this scheme of rotation between caregivers and caregivers between caregivers and patients. So the complexity increased considerably in this problem. So just some more details. So we have, I already mentioned, bedridden, but also semi-dependent patients. It's 8 to 8 service, the visiting, and it goes from once a week to 4 times a day. In this organization, there are 9 caregivers. They are all women with homogeneous qualification. Here in Portuguese reality, we don't have the language problem. More or less everyone speaks Portuguese. And in terms of religion, almost everyone is Catholic. So there's not really a problems of religion backgrounds and language. And also most caregivers are women in this type of jobs, not nursing. Nursing, we have male nurses, but in this type of social services are mostly women that provide the service. So ideally, the Apoio wanted teams of 2 for bedridden patients and just a single caregiver to visit semi-dependent, more autonomous patients. They all depart from the daycare center and should return at the end of the day. Also, they should take a lunch break of 1 hour at the daycare center, and they walk or drive to and from the patient's homes. And 3 of the workers have to arrive earlier to the daycare center because they have other activities they are needed, in particular in the meal delivery. So the scheduling we are going I am going to speak about not take into account the meal delivery. This is a different service, but these workers, they work in several different activities. They are not dedicated to a home care service. They do other things in the daycare center. So this just for you to have an idea where the patients' homes are located. We worked with, I don't know if you see my mouse. Do you see the mouse? It's okay. So we have the daycare center, and then we have more or less 3 clusters of patients. This is near Lisbon. It's not Lisbon, it's very near Lisbon. And we have some bedridden and some semi-dependent patients that are visiting currently. And the crosses are new patients that they wanted to visit. So they are patients in the waiting list, which is quite big. It's scarily big, the waiting list. And so one of the topics we want to address was if there's time available to visit more patients, which would be the new patients to enter the system. So that's why there are those different patients in there. So this work has been published in European Journal of Operations Research. I'm going just to give you some just brief highlights of the conclusions we have reached with this work. So to define the work schedule for each caregiver, and given all the rules that the allocation of patients to caregivers we have been asked for, we decided to split the problem in 2 different problems. So one, we deal with the patient visiting time in the sequence of the visit. So this is the scheduling, routing of the caregivers. Not the caregivers, but the teams of caregivers. So there's no real person behind these teams, they are teams. And then we, in a different analysis, we compose the team. So we said which caregiver would be part of which team. And so we could separate the decisions concerning the visiting times and the sequence from those that assure the rotation scheme that the social caregiver had asked us. So just for you to have, we split the problem in 2 and it's bedridden patients and semi-dependent patients. Since these need two teams of 2 and these only need teams of 1. And for the bedridden patients, we could improve the total working time in 34. And for the semi-dependent, this was about 40%. So 2/3 to almost half of the time, we could improve the total working time. So we had quite a lot of free time to work with. And this allowed, this green space allowed us to choose or to think about which new patients could be served by this same team. So it was quite a good improvement for the organization. Patrick also mentioned workloads. So those improvements we saw in the previous slide didn't consider workload. So there are teams working almost all the time in patient visit, and then there are other teams that work lesser time. So this is not very well accepted among the caregivers. That are some that have heavy weeks and some that have easier weeks, although they all rotate in the teams. So if in 1 week they were with a heavy workload, in another week they could have an easier workload. But even though we decided to look for a more balanced structure and or visiting sequence, a sequence of visiting, and then we got this more level and more balanced workload. So we start by trying to minimize the team that work the most, and then with that solution we try to improve the traveling time using that solution. So in a more balanced solution, so we pay the price of more travel time. That's the cost of this more workload balanced solution. And then we presented this. This is what increases in terms of the travel time. So now it's for the association to decide if this is a good trade-off or not, but at least they have the information of the impact if they want a more balanced workload. So since we have all that free time, or at least the available capacity for these teams of caregivers, we did a small exercise to try to understand which patients and how many patients, new ones, could be visited with this data. So for the bedridden patients, there's 10 new visits that can be made, but this corresponds to 2 new patients. Okay, so each patient needs 1 visit per day, and this is a weekly plan. This is not a daily plan. This is a weekly plan, and so there's 10 visits, and this increases the time in 27%. Notice that we in this analysis we decided to keep the current visiting plan unchanged. So the optimal solution or the good solution we find previously was kept unchanged. We know that many seniors do not like to see their visiting schemes change a lot. So if one day they are visited at 11 a.m., they don't like the next week to be visited at 3 p.m. and the week that follows to be visited at 4 p.m. They like the life to be a little more stable in terms of this kind of visits. So in this exercise, or in this test we decided to keep the planning, the previous planning, and change. We allowed for a change of 5 minutes, more or less 5 minutes, with a 10-minute change in the daily visit. And so that's why there's a large impact on the traveling time, because we didn't perform the best routing with these new patients. Okay, So for 11 visits, there's no solution, which means that it is impossible to perform 11 visits in this example, in this context. And so just for you to have an idea, what happens is that there was some space, and it was adjusted to add these new patients. Okay, so the lunch is a little bit, things have moved a little bit so that we could account for everyone in this full capacity plan. We did a similar exercise for the semi-dependent patients, and for those we could perform 6 more visits, which correspond to 3 new patients. And again, we imposed the same constraints of not changing a lot the previous plan, and so we also had some increase in the travel time. This is just the solution for the other problem, which is which caregiver should work in which team and in which week. It's the decision, so we have to do for this case. It seems a quite easier solution, and when we present this problem, sometimes people get a pen and try to come up with just some scheme, and it's harder than it seems, and everyone at the end says, oh, this is quite harder than it seems. And in fact, each colors correspond to a caregiver. The white here, the blank are a fictitious caregiver, since the semi-dependents are only visited by one caregiver, and the scheme in fact imposes is on the 2-person teams. And the rules were at least one caregiver would be the same in at least 2 consecutive weeks, and sometimes they stay 3 weeks. I think there's here. This one, there's a caregiver for 3 weeks. And also another imposition is that all caregivers work with all colleagues, and all the pairs or the color pairs appear if we check. And also that all caregivers visit all the patients, and you can see that, for instance, green, it's quite easy to see. It appears in all the teams, so it means that it will visit, this caregiver will visit all the patients. In addition, we imposed a new constraint that it was not asked, explicitly asked, but we thought it was a good thing to do, was that the last week would match the first week. So we wanted what we call a rolling horizon, so that a scheme of change between the weeks would be fixed in a period of, we didn't know at the beginning how many weeks we needed for this scheme to be applied in a continuous way. And we found out that the minimum number of weeks we needed was 12 weeks. So from 12 to 12 weeks, we can start again, and the scheme will be assure all the constraints that social worker asked us for. And so this is not my work. This is a work of a team of people. So Tanya, Rams, and Giacomo were 2 of my colleagues working in this project, and had some students. Raquel is now doing a PhD in this topic, and she's now addressing the problem of synchronizing the visits of the caregivers. So we split the problem in patients with 2 caregivers and patients with 1 caregiver, needing 1 caregiver, but sometimes they live quite close. And so why not to have a team of 2 visiting patients, bedridden patients, and they split and visit semi-dependent patients, and if needed, they get back together to visit a patient that needs 2 caregivers. So that's what she's addressing right now, is to develop a model that can do this type of synchronization work. So this is still some work in progress. We never finish in this type of problems. I hope I didn't take too much time. I didn't control the time.
No, thank you so much. I mean, it was almost in time. We were late for technical reasons, so I'm going to ask you to stay at least for 5 minutes. Or thank you so much, Isabel, for your interesting work in social home care, which is going to be more important as the healthcare in the future, I believe. And remember that any of our attendees, if they want to ask questions, please make them write them to us, and we will distribute it to Isabel and Patrick for answer. But I would like just to finish with one question for both of you. It's a very general question, but it's like, what are the main learning lesson and recommendation you can come out of after working so many years in this topic, especially for young researchers that want to start in this topic? What is the main learning lesson, and the main recommendation? So by the order, I will start with Patrick and then Isabel.
Thank you. Yes, I think it's not just because we try to optimize something here, but for me, it's quite important also to think about what we are optimizing. And we are optimizing a very social system. We have to give care to clients. And I think it's quite tough to say, okay, you can't just stay there for 30 minutes because you are paid for this 30 minutes. And it's also very tough for home healthcare nurses sometimes to say after half an hour, I have to leave now, even if the patient is in a bad condition. So I think we have to think about that the times are not so fixed as we want to have them. And the other thing is also, if we want to optimize, we need to think that home healthcare nurses do a quite tough job. And it's especially here, it's quite hard to find people for that job because the payment is, yes, a little bit worse than if you go working in a hospital and you have all the problems that you don't have colleagues during the day where you can interact with each other. And it's also, I think we should also think about all these social implications also for the home healthcare nurses when we try to optimize something. And we have tried that in our last work with getting some criteria that are important for them. And there are some things we haven't thought about before, to be honest. And I think we should think about that, and we also should think about alternative mobility concepts. And
Thank you so much, Patrick. I think
totally
Isabel is now your turn.
This is a routing. We've been studying mostly in terms of techniques as a routing problem, but we are not delivering parcels, and which are objects that can stay more or less intact inside of a van. So these are people servicing people, and people in very needing conditions. So it's not people in I will say normal, I don't like the term, but they're people with frailties, and so in special with needs. And so we must not forget that that's the work we've been doing. It's not a work for some product to be changed from place to another, but to assist people, and this is very important. A second thing I would say is that do not forget to speak with the ones that need the services and the ones that will need the tools. They know better than us what they really need and what are the constraints, the implicit constraints that we don't see if we look it's just from an academic point of view or just reading some papers. So because some of the issues are cultural issues, and the cultural issues in Portugal are not the same in Sweden, and so, or the same in Vienna. Some are the same, but others are different. So it's very important to know the reality and speak with the persons that are on working in this kind of job, not to be imprisoned by what they need, because we need to think a little bit outside of sometimes what they need, but to hear them and try to come up with solutions that that will provide them that will provide them benefits, and not just to do it for research pleasure, which is just enough to read some papers and invent and come up with a new idea just because we like it. And it's not really what we are trying to do here.
So thank you so much, Isabel and Patrick. You know, it's a great pleasure to have you. I know, you know, that we admire very much your work. The group is following you very closely. It's a very interesting, this research focus on to people by people, as you said, which is quite interesting. And I think the pandemic also teaches that this is going to be more important in the future than we probably thought before the pandemic. And also for the young ones in the group, I think we have a new line of research. Which is optimizing not only the cost, not only the benefit, but optimizing the social return. So what is the social return of our research, and how can we contribute to this social return? So this is a huge line of research. So we have a lot of work to do here. So now I pass to Jessica so she can conclude the meetings. Thank you so much for being here.
Well, thank you so much, Isabel and Patrick, for accepting the invitation and for your nice presentations. We are running out of time because we start very late. So that's all. Thank you so much. Hope you have enjoyed this webinar.
Okay, thank you so much. It was a pleasure to be Zoom with you. I would prefer to be in Barcelona, but we'll meet in person soon, I hope.
Thank you very much for the invitation too. I would also have preferred to be in Barcelona and to see you in person, but I hope we will have that opportunity soon.
Yeah.
Or in Lisbon, I think. I also like Lisbon.
Yeah, Lisbon is also very nice.
Okay, thank you. Bye.
Bye.
Thank you very much.